Okay, our presenters are Dr. Jennie Green, who is a board certified child abuse pediatrician at Children's at UK. I skipped the name because I'm not sure I know how to pronounce it. Dr. Green completed medical school at University of Florida in 2014. She then completed general pediatric residency and child abuse fellowship at University of Louisville. And also accompanying her is Dr. Kelsey Gregory as a child abuse pediatrician at Children's at UK. Dr. Gregory completed her medical training at the University of Louisville School of Medicine. She went on to complete her pediatrics residency at Vanderbilt University and her child abuse pediatrics fellowship at Ann and Robert H. Lurie Children's Hospital and Northwestern University, McGraw Medical Center. So with that, thank you all and welcome.
Thank you. Hi, everyone. I'm Kelsey Gregory. Again, we are child abuse pediatricians, Dr. Green and I. If you don't know what that means, we are pediatricians by training, and we went on to do secondary training in child abuse pediatrics. And so our primary role is to help medically evaluate children whenever they have experienced abuse or neglect, or we think they might have. And so as we are evaluating these children, we understand that we become involved in their lives kind of on the back end of things after an injury or harm has occurred in their life, and spend a lot of time thinking, what if? What if something were different prior to our involvement? How could we have prevented this? And there are a number of different reasons our team gets involved, but some of the somewhat common calls we get are about firearm injuries, and unsafe medication storage or ingestions, intoxication in young children. And those two, Dr. Green and I felt like, gosh, these are kind of low-hanging fruit. While the subject of substance use or firearm ownership is quite complex and difficult to discuss, keeping children safe from those things is pretty simple, or at least it should be. And so we have been approaching firearm and medication safety in the pediatric setting at UK, now Golisano Children's Hospital. So it is taking us some time to get used to that too. So for today, we're first going to talk about our firearm safety project we have going on. We'll first talk about epidemiology related to firearm injuries, specifically in the pediatric setting, and talk about how we're trying to approach this from a general pediatrician's perspective, what we can do to help prevent these injuries, and how we can address some barriers in doing so, and then talk about our next steps with that project. So I'll talk about that first, and then Dr. Green is going to talk about our medication storage and naloxone prescribing in pediatrics, again, talking about the issue at hand, specifically with kids, and the overdoses or intoxications that we see in children, as well as how we're addressing that from a prevention perspective, primary and secondary prevention perspective. So we'll start with firearm injury prevention, and this is really geared towards providing education and resources to caregivers in an outpatient pediatric setting. So we currently know that firearm injuries and deaths are a huge issue in our country, with there being at least 48,000 firearm deaths in 2022, including homicides, suicides, and accidental deaths. And that's about 132 people dying from a firearm-related injury each day. And that includes peds or children as well. So over the past few years, we have seen that firearm injuries are the leading cause of death in kids and teens. And I find that to be, when I present that statistic, to be pretty alarming and surprising to people. It has overtaken motor vehicle crashes as the leading cause of death in children. And even when we break down the age of children, this is the fourth leading cause of death in infants, which is incredibly surprising. And unfortunately, that's remained true throughout the last few years. So this is back in 2020. The JAMA Pediatrics just published this report on how firearm-related deaths have surpassed motor vehicle collision deaths in the past about 4 years plus. And they go on to show just kind of how this phenomenon has gone about, where, you know, in the early 2000s, the blue represents MVCs or motor vehicle collisions. And as we progress through the mid 2000s to now, the orange is firearm related deaths being higher in that state than motor vehicle collisions, and Kentucky is now one of those. Again, it's really a risk for kids of all ages. I think when we talk about firearm injuries, people often think about older children who can access guns, or may be involved in using guns in social scenarios, perhaps. But we know that the second largest group, or kids 0 to 5, are the second most common age group to be killed from a firearm. They've done studies to look at, can kids even use a firearm that young? And studies have showed that kids as young as 3 can pull a trigger on a firearm. Possibly younger. So there's some anecdotal studies or reports out there that kids as young as 18 months have the physical capability and strength to pull a trigger. So we absolutely can see this happen in children that young. We do see a higher proportion of firearm deaths in boys. And what are the circumstances surrounding those deaths? When we look specifically at what we're seeing, we know that the majority of the firearms involved in pediatric deaths were stored loaded or unlocked. Usually it happened in somebody's house, so a place they were familiar with, and somewhere that was easy to access the gun is where the gun was kept, like a nightstand. Most of the time, the child was playing with the gun as a toy or showing it to a friend or someone in the home. And most of the time, shooters were shooting someone they knew. So a friend, a sibling, a colleague, someone in their family. Not a colleague. Unless they're, working young. So we know just based on this information that these are preventable deaths. There are over 4 million children living in homes with unlocked and loaded guns. And so by default, those kids are at risk, no matter what age they are. But we know that it has been postulated that if households were to lock their firearms and store their ammunition separately, if they were to store their firearms safely, we could decrease deaths in children up to 85%, which is huge. So we asked ourselves, are pediatricians equipped to really handle this conversation with families, and to help them? So we asked them. We wanted to know what they were doing and how they felt about firearm safety screening in their practice. So we just surveyed UK pediatricians in Lexington and asked them about a couple of different things. First was their attitudes towards firearm screening, if they felt like it was important to do it or not. Was it feasible with the time that they had and in their clinic space? Did they think it was effective? And were they comfortable with it? We also wanted to know what they were doing, if they were doing it. So if you screen, how are you doing it and who are you asking? We really were interested in knowing, are you screening or just doing universal education? Because there's some interesting thought into the differences between those two approaches. And what are you doing if it's yes? Are you providing education, resources? What is the next step for you? And lastly, we wanted to understand barriers because we wanted to know how to help pediatricians better address this.
And part of the reason that firearm screening came up in pediatric offices is that Medicaid started reimbursing it as a screen that we do with kids. So a lot of our anticipatory guidance was like bicycle helmets, safe sleep, water safety. Well, firearms are now kind of counted within that bulk of things that pediatricians have to screen for, not only to get reimbursed by Medicaid, but to have essentially like complete charting and things like that. So we were unsure of if they were asking the questions, like how were they checking off that box that we know as pediatricians we're supposed to check off.
So we sent this out to, again, pediatricians at UK in the Lexington area, as well as advanced practice providers, so nurse practitioners or PAs, and then our pediatric residents who practice in Lexington as well. We had about a 30% response rate, which is not great, but apparently physicians are not good at responding to surveys in general. So I'll take it as a win. And our experience ranged from, pediatric residents in training, their first year training, up to someone with 20 years of experience in the field. So there was a good range there. And so this is what we learned. We used a Likert scale for most of our questions in the survey from 0 to 100. 0 being, for example, something is not at all important, 100 being it's very, very important. What we found is that pediatricians found that both screening and firearm education was incredibly important to do in their pediatric setting. And they felt like it was mostly feasible, that they could do it. They also felt like it was pretty efficacious, that it had some effect in preventing firearm deaths. But what was really interesting was the information we got regarding their comfort in firearm screening. And so I want to delve into that a little bit more in detail. If you look at simply the survey responses with the Likert scale of how comfortable are you doing this, people say they're really comfortable. And so we actually had a mean of 100 being, I am very, very comfortable screening for firearms in my pediatric setting, and a pretty high response rate for providing education as well. But we gave them the opportunity in the survey to provide some free text responses or just provide us a little bit more information, comment section. And what we learned from that is that they felt like they didn't have enough knowledge to provide education outside of keep your guns stored safely, keep them locked and unloaded. They also had some difficulty with having conversations with parents of different professions, which I'll talk about in a little bit. And they talked about worrying about offending caregivers and the potential fear of political debates. I'll talk about our intervention, our education in a little bit, but anecdotally, when we were providing the education, we also learned some other discomforts that providers had. And one is the minimal understanding of the true epidemiology of firearm deaths in pediatrics. Some of the statistics were surprising to our pediatricians. They didn't really know the length or depth of firearm injuries related to all ages of children. They were uncomfortable with firearm anatomy and how to use the lock mechanisms that we talk about. And they had some difficulty with modifying their conversations with families to fit their specific needs with regards to storing firearms safely. And this came up in ways of, there might be families that say, I have to have my gun near me because of X, Y, or Z. Then being able to work with them and say, okay, if you have to have your gun near you, here are the other ways you can keep that safe. And just modifying their kind of spiel was something they weren't quite comfortable yet with. We went on to ask about current practice. So who do you screen and how? I'd say that who pediatricians are screening varied quite a bit. Some said every well child check they do it. Some said when I remember. Some said if it's a new patient I'll ask, but then I usually don't ask again. And then one person actually said everyone under 2, which I found interesting and had more questions about. The vast majority indicated that they were doing verbal screening, so asking families and caregivers directly about firearms in their home. But a lot of people suggested that they wanted a written screen, that would save time and perhaps be more efficacious in their clinic setting. We unfortunately didn't really get a clear understanding of who was doing universal screening versus universal education. And what was kind of unfortunate is that when we talked about resources, most providers said they'd provide some level of education to the family, but only about 20% provided other resources, and there were 10% that didn't do anything. So they would screen, but then they wouldn't provide education or resources to the family if that screen were positive.
And the education, like Dr. Gregory had already said, was store your guns unloaded with the ammo in a separate place. And pretty much a lot of our families are like, well, if I use it for personal safety, that doesn't make any sense to me. So it's one ear out the other.
Yeah. And then again, our comment section about barriers led to a lot of interesting information. So by and large, the biggest thing that came up was time, that there was not enough time to talk to families about this difficult topic. And some people even talked about the presence of learners. We're a teaching hospital, and so we have medical students and residents working with us. And so that limits our time to be able to have one-on-one conversations with families as well. Parent occupation, like I said, came up. So multiple providers said, I'm actually not comfortable talking to, say, a parent that's in law enforcement about guns because they know more than I do. And so I don't feel like I can have that conversation. They talked about parents' willingness to participate in the discussion and not really knowing how to proceed if a parent kind of shuts down or is not very engaged. And then again, lack of knowledge to providing education, not knowing what else to say other than keep your gun locked away. So we wanted to address these gaps to help our pediatricians address this issue a little bit better and have more comfort in doing so. So we developed a provider education model, and we felt really strongly about doing this in person with them in order to provide a more interactive environment and a hands-on teaching environment. The topics we go over is epidemiology, but then we go into gun laws, gun anatomy, and language to really teach them about just the basics of what certain gun words mean. And we by no means are experts, but to develop some information so that we can have conversations and know how to talk about where to put a gun lock and what part of the gun the locks go on and that sort of thing. What sort of lock is appropriate for one gun versus another gun? We spent a lot of time discussing universal screening versus education. There's been a big push in the preventative medicine world to really go towards universal education because we know when we ask families about things like drugs, alcohol, firearms, things that they may not want to talk to physicians about, they might be likely to say no to avoid the conversation. And that sometimes prevents us from providing education that people need. The other side of that is that even if someone doesn't have a firearm in their home, their child might be exposed to a firearm somewhere else. And so the education is still important for them, whether they're a gun owner or not. And so there's been a real push in all of preventative medicine to really go towards this universal education. We gave specific online resources for providers to provide to the family. And we focused specifically on firearm resources that were developed by gun owners or groups that that had guns, essentially. So the NRA has some good educational models. So we pointed providers to the NRA as well as Kids Safe. Yes, thank you. It's like I have it in my notes. Kids Safe is another organization that promotes safe firearm ownership. And they kind of have different hubs throughout the United States, but have a lot of good online resources as well. And we felt that that helped with the barrier of parents feeling judged by non-gun owners or being told what to do by someone who doesn't understand their lifestyle.
And some of the education really was targeted towards children. A lot of parents, so they've done studies about like parental beliefs and they're like, well, I told them not to touch it. And then that's so they know to listen to me. They know it's dangerous. They know it's this, they know it's that. Well, it also looks like a really cool toy and there's lots of toy guns on the market. And so it's a very confusing message. So like NRA has Eddie the Eagle and there's like certain scripts that they follow and videos that he has specifically for different age groups of children. And same thing with I can't remember who Kids Safe has as their little person, but so they're meant for children. It's like treat the gun like a snake and like they have like 4 steps they take. So it's kind of it's something that's a little bit more concrete.
Yeah. Like Dr. Green said, we talked through the billing aspect of this, so that hopefully addresses the time concern and that they can bill for their time talking about firearm safety. And then we do some scripting with some destigmatization. And so our big approach is approaching this as preventative or injury prevention in general. We talk about car seats, we talk about fire alarms, we talk about safe sleep, and we talk about firearms. It is now, we should just group it in those other commonly discussed safety measures for families. And then what I really like is we do hands-on practice. So here's a picture of our very fancy gun that we take to do our education. And we allow participants the time to handle the gun, hold it, see the different aspects of the gun, and put the lock on there so they know how to teach the family how to use it. The other gun lock that we have been using is like a trigger lock, which I don't have a photo of, but this is a cable lock here. So we give them an opportunity to work through this so that if parents ask them questions, they know how to answer that and show them how to use it.
For the trigger lock in particular, so this is plastic. This doesn't, it's not real. I think that's obvious by
If
the
you can
colors,
tell.
but yeah, but the magazine comes out, it does all the things that, most of the things that guns do. It has even like a little safety, although a lot of guns don't have safeties now, which is a whole other thing. And one of the big things with the trigger locks we found when we were doing the education is like a lot of physicians don't know how the trigger lock like works on the gun, and that one of the biggest pieces of guidance you give families if they are going to use a trigger lock is don't put it on a loaded gun because it might flip the trigger and actually shoot the gun, which has happened. And so kind of like working through that with them kind of made them realize like, yeah, if I put the little like barrel of the lock in front of the trigger and push back, then yeah, I could totally accidentally shoot a gun if I were putting it on. So it kind of made that a little bit more like real, I guess, or a little bit more logical to them.
Mm-hmm. Yeah. We also provide physical resources whenever we're doing this education. So we take cable locks with us and provide those to the clinics that we're working with. We worked with Prevent Child Abuse Kentucky, hi Chris, to develop a checklist to give out to families about gun safety and how to keep their guns safe in their home. And then the middle came out of one of our sessions, actually. One of the providers asked, like, hey, can we get some signage for our clinic that might prompt families to ask about this themselves if we forget. And so we developed some signage that indicates, hey, we have trigger locks, you can have them, they're free if you'd like them. So UK, the communications department worked with us to develop that. So this is what we've learned. We're still in the process of carrying out this intervention and gathering some, post-intervention data, but we are doing a survey of participants again, and about 92% of them are saying that they're learning new information. So again, the new information that they're learning, they're saying they know more about the breadth of the problem, including that this is the leading cause of death in all age groups. And specifically in Kentucky as well, in pediatrics. They are learning basic information about guns, gun laws, and locks in order to provide more tangible guidance to families. And there is an increased intention to provide this education and resources to their families. What we've observed is that this hands-on practice has really helped with being more comfortable with the mechanisms we're providing. And really people are seeing the benefit in shifting towards universal education and providing this information to all families in some way, just trying to figure out how that might work in the time constraints in their practice. But really adopting it into a safety topic that they approach with all families. And we talked a lot about adjusting our approach for family-specific needs. So families that indicate they have to have their firearm close by. Okay, can it be close by, but with the ammo separate? Or if you have to have it loaded, here are the different locking mechanisms that you can use safely with a loaded gun and still keep it locked and safe and tucked away. So next steps, we're going to gather some more post-intervention information, and we're hoping to get some qualitative data from caregivers who were provided education by their pediatrician and any sort of resources. We expect that families probably don't love cable locks, but that's what you can get for free or pretty cheap. at this point. So we're hoping to understand their preferences on storage mechanisms and use some of that data to get funding to get the preferred method of storage. And we'd like to expand this education. We're working with some other groups, specifically the OBGYN world, to expand some of this information to their population as well. And that might include combining these projects of safe firearm storage with safe medication storage for families that might need both. So with that, I will let Dr. Green take over.
Okay, yeah, jump in whenever you want, Dr. Gregory. So I'm basically going to be talking about our other big problem, which is pediatric ingestions, especially here in Kentucky. You know, much like the rest of the nation, but also uniquely, we have a massive substance use disorder problem. We also have a lot of folks who had substance use disorder and are in recovery, but are still taking opiates. So it's a very profound population of people. A lot of them have children, whether they live with them or they visit them, whether it be grandparents or whatnot. So there's a lot of need essentially with regard to this. Even just looking, again, zooming into just Kentucky, the external panel is something that our medical director is one of the heads of, or one of the panelists of, and essentially what that looks at are CPS involved families for near fatalities and fatalities of children in Kentucky for each previous fiscal year. And they found that in general, of all the cases that they reviewed, that there were 55 cases of childhood ingestion in 2022, which doesn't sound like a lot, but keep in mind that a lot of childhood ingestions are either not tested for appropriately, which I'm going to go into later, or they're not reported. So there's definitely a lot of reporting variability that can contribute to this. Opiates, again, were going to be one of the major things that we saw that kids are ingesting, whether they be synthetic or non-synthetic. Sorry about that. We also saw that the vast majority, up to 90%, are occurring in kiddos less than 4 years of age. When we look at Kipric data and compare the same year with Kipric data, the data is vastly different. I'm sorry. The air is very dry. With Kipric data, they saw that in Kentucky, 721 children 4 years of age or younger, so just that age group, were seen in the ER for ingestion-related medical issues, with 72 requiring hospitalization. That's a big jump, that 721 to 72. And one of the things I did want to point out, just with how medical systems work, is that typically when you call poison control, you're telling them what you think they ingested, what they tested positive for, and the duration. Thank you so much. They're telling you, you know, observe them for 12 hours or this long after they've gotten Narcan. So a lot of times they'll stay in as ED holds to prevent them from essentially taking a room that we know that they may not need for very long. So even though only 72 required hospitalizations, there's still a large portion of that 721 that was obviously affected by the fact that they ingested. The most disturbing part is that the near fatality and fatality rates have just doubled. So between 2020 and 2022, went from 4 to 8 child fatalities. Again, that could be a factor of screening too, that we're getting better at identifying toxic ingestions. 44 near fatalities and 47. And then in fiscal year 2023, there were almost double. So 15 fatalities identified and 61 near fatalities of children related to overdose or ingestions. Again, that doesn't seem like a lot. I think it's quite frankly a vast underrepresentation of what's going on, but those are the numbers we have to work with, and they're not very uplifting. Obviously, child abuse medicine, substance use disorder is going to be a risk factor for abuse and neglect. We see a lot of, you know, disinhibition, impulsivity, maybe some aggression depending upon kind of the drug of use. We know that in general in Kentucky, about 40% of CPS investigations involve at least one caregiver who's named in the report having substance use disorder. The national average of substance use is about 25%, so obviously we're much higher than that. And then in Kentucky, with regard to near fatalities and fatalities, they found a little over 50% had substance use disorder as an identified risk factor upon investigation. when we're talking about toxicology tests, one of the things that is most important and that I've tried to work on over the course of my career is helping people understand what they're testing for and what they're not testing for. With children, especially with young children, right? Since we're talking about the 4, 5 and under age group, which is so vulnerable, unfortunately. You have to do testing that maybe is not your standard urine drug screen that you would get in the ER, which is consistent with essentially the type of drug screen you would get as an adult doing an employment screen, essentially. The thresholds are way too high, quite frankly. Even a very intoxicated child can be negative on a drug screen, but if you test them with the more sensitive methods, you will find that they're positive, quite frankly, they're confirmed positive. So one of the other things, and I'll show you how those tests look a little bit later. The other big thing is that you have to know what substances you're testing for. You know, fentanyl's replaced heroin, and it has for a while now as one of the top opioids that folks are abusing, using in general. Most of it is illicit. The important thing to know is when you're doing a drug screen in the ER or in some type of clinic, if the drug screen doesn't specifically say fentanyl on it, and it just says opiates, then the likelihood of that you're actually testing for fentanyl on that drug screen is very low, if not zero, because the opiates that are contained within that urine drug screen are naturally occurring. They're morphine, codeine, things like that. They're not the synthetics. So the main synthetics are going to be fentanyl, buprenorphine, and methadone. Semi-synthetics include like oxycodone and OxyContin, which a lot of time, again, are not included in that opiate screen. And you're not going to know that because the way that the result comes out is this. It doesn't say, and so this is our lab. So our lab does include fentanyl. More and more hospitals are including fentanyl, but not all. So that it's important to know. Again, not as many are including buprenorphine or methadone. Fentanyl, just because of how popular it's become in the last couple of years, has started to show up on more drug screens, thankfully. But even just in the last couple of months, we had a case where a kiddo came in. They were obviously intoxicated by something, but they had drug screens at an outside hospital. Everything that they did was negative because the thresholds were far too high. And then essentially they had also tested the parent, and they found out the parent's drug of choice was fentanyl. They tested the parent was negative for everything. So now you have a child who had clear signs of intoxication, got Narcan, got better, yet is negative on everything. Now you have a parent who's negative on everything. I asked to look at the drug screen for the parent. It didn't even have fentanyl on it. It had opiates. So we had a conversation about how they didn't test for the right thing. And if you're a chronic fentanyl user, it can show up for multiple days, but obviously there's ways to kind of speed up metabolism and clean that out that folks who abuse substances sometimes know. So there's that caveat too. So essentially it's also about just keeping kids safe and knowing what the results mean and what they don't mean. So at UK, the testing protocol we use when it comes to children is if a kiddo comes in less than 18 years of age, there's substance exposure identified or suspected, we go ahead and we order these 3 different tests. The drugs of abuse screen we order, even though its thresholds are high, because it can come back very quickly. And if it's an older child and they have a large load of drug, then we can at least find out what it is early on. That being said, there's been plenty of times when we dual order the pain management and the comprehensive urine drug screens, which are much lower thresholds. They do take 2 to 3 days to come back. They're much more sensitive tests. They're much more complex tests. But urine drug screen will be negative on the 4-year-old, and then 2 days later, the pain management comes back with methamphetamine and fentanyl. That's happened a number of times at this point. So obviously that drastically changes the safety profile of the household they were in and kind of what's going on. And that's something that you can take, unfortunately, to the family court system and be like, here's evidence that this child was affected, and what are some steps that we can do to keep them safe. Okay, so here's that drug abuse screen. So just keep in mind the thresholds are being super high on that side. This is the pain management. So this is my favorite one because it includes THC. It includes all of our fun different things. It doesn't include xylazine yet, but our comprehensive is working on it. But this is the one that we typically will identify that subacute exposure or that lower threshold exposure where the child's maybe symptomatic still, but they're not showing up on that typical, adult EDS. And it includes a lot of the metabolites, so the breakdown products. We also offer something called Child Guard hair testing. It's through the U.S. Drug Testing Laboratory. That's the send out it goes to. And that helps to detect both passive and active exposure. We can't differentiate between the two, but if we get a call, hey, we're concerned that there's substance use going on in this child's caregiving environment, as long as the child is age 1 or over, we can test them. And we can identify if they've at least been exposed to things like methamphetamine, fentanyl, different benzos. This is just a result of a Child Guard 13. 13 is just the number of drugs included in the panel. But again, it kind of gives you an indication, even if the child hasn't had an acute ingestion, near fatal or fatal event yet, if they have evidence of passive or active exposure in their hair, then at least we can do some safety planning. Well, not us. CPS can do some safety planning, and we can offer resources as well from our end and our LCSWs to be able to address substance use issues that could place that child at risk. One of the things that started about 5 years ago at UK was essentially the lock bag safe medication storage program. I like to call it the safe substance storage program for a very specific reason, which I'll get to. But essentially, thousands of lock bags have been distributed across the state by UK PFM, as well as educational materials that have been developed with our team. Our team has distributed about 80 plus with regard to our subset of patients that were consulted on, which seems low, but UK ED, so our social workers in the hospital, actually give out the lock bags pretty frequently as well. So sometimes they get to it before we do, quite frankly, which is good. Again, about 30% of those ingestions that we've personally been involved in and provided a lock bag have been with regard to opioids. The other ones are going to be like methamphetamine, sometimes benzos, but TIP and THC are going to be those big three that we see. We tell people, the reason why I call it safe substance storage is because we tell people to store anything in there. If you have pot, if you have THC products, gummies, whatever, if you have, methamphetamine in a Benadryl bottle, again, have had that case too. Just put it somewhere that's locked up, because children have no idea what you have decided to store in those containers, and they can be horribly affected by it. That's just a picture of the lock bags here. They have like a little, they have a lock on them. It's not exactly pictured in this. I think it's right here. They also have the poison control number. They also have this infographic that was developed with Face It, as well as multiple other partners, including our team, as to, the statistics with regard to childhood ingestion, as well as tips how to safely store medication. This is just another infographic that our team helped to develop. Essentially, that again it's bright, it's colorful, it's meant to kind of engage folks and make them very aware of this risk. I say substance highlight THC because there's like four or five different types of THC at this point, and at least 3 of them are readily available in gas stations, and they're highly used, and they're not closely regulated. So the Delta 9 THC that we all know as psychoactive marijuana could potentially be in those products as well, because the regulation of Delta 8, Delta 10, and THCP is not very stringent. So, they're allowed to have a certain percentage of Delta 9 in there, but the fact of the matter is if nobody's checking, then they might not know. The other thing about THC products is that they come in every type of commodity you could think of. Wonka bars, chocolate bars, baked goods, there's Doritos, there's pretzels, there's these things called dabs that look like honey. Gummies is probably the most common ingestion that we see with kids because they look like gummy bears. So the child eats the candy, and then the child goes to the hospital, because THC ingestion in kids is actually a really serious thing. It's often a near fatal ingestion. As you can see, the milligrams in these are not low, and children are just kind of eating everything that they can because they find a candy bar, they're going to eat however much they want of the candy bar. And again, a lot of our kids are toddlers. They can't necessarily read, and even if they could, they wouldn't know what this means. So, it's a very difficult problem to have. A lot of folks, sometimes they're buying just the one-off gummies and leaving around, but even those one gummy packs can have like 1,200 milligrams of THC in them. When kids come in, a lot of times they're obtunded, so they're sedated to the point that they're extremely difficult to arouse. They have breathing problems. A lot of times they need to be put on oxygen. Seizures is actually a really common manifestation of THC overdose in kids, and we've seen it quite a few times ourselves, and it is reported in the literature as well. So all things that are very terrible for children. They almost look like they've honestly ingested opioids when they come in, and then it ends up being THC. So it's been a little confusing, just the degree to which that they are affected. So anyway, that kind of goes into, if you have marijuana or THC Doritos, go ahead and just put them in your lock bag as well, because they just look like regular Doritos to everybody else. Naloxone is kind of the last thing, as everyone in this room knows. Naloxone, otherwise known as Narcan by its trade name, life-saving medication. It only reverses CNS depression, cardiorespiratory depression by opioids. It doesn't matter which opioid it is. That's exactly the mechanism of action. That's exactly what it works on. The only contraindication to actually giving someone naloxone would be if they were allergic. And even then, there's really nothing better to give someone for an opioid overdose. So they're like, just give it anyway. And the number of people who are actually allergic to naloxone is incredibly low. That's a relative rarity. Getting it over the counter, it's pretty expensive. It's about $50 a pop, whether you get it at Kroger or CVS or Walgreens. Medicaid does cover one naloxone prescription every 30 days, and that includes for children as well. So that's something that we researched to try to say, you know, what can we do for children? The dose that's provided is that 4 milligram dose. It's safe for literally any age, from the youngest of infants to the oldest of people. And again, there's a lot of education about, you know, especially with kids, like, don't just give them half of it because you're afraid how they're going to react. Give them all of it, because what ends up happening is once that gets cycled through their system, and it's pretty quick, a lot of times they end up requiring more and more naloxone at the hospital. So trying to educate caregivers about, you might have given naloxone to another adult before, and you might have not had to take them to the hospital, but that's not how kids react. A lot of times kids metabolize it really quickly, and they end up needing drips and multi-doses and things like that. So the advice that we give parents is, if you're giving a child naloxone, which happens sometimes in the home environment, you have to call 911 right away, because it's very likely that that one dose is not going to be enough. So when we talk about pediatric education with regarding naloxone, we talk about, you know, the dose is okay for the youngest of infants to the oldest of people. Give the full dose. Don't try it out. Don't give them half the dose. Call 911 right away, because they're going to need more. We try to be very straightforward about what naloxone is and isn't in terms of like life-saving maneuvers in the home environment, and that it's not something we can just kind of keep under wraps and hide, thinking that children are just going to be okay. Because as we see here, even from, you know, CPS reports and you know, inapproximate testing and things like that, our numbers are quickly doubling with regard to how many kids are dying every year. The UK adult naloxone program started in 2017. Currently, they distribute about 100 naloxone prescriptions. Usually it's like a meds to bed situation. So they're walking out with Narcan, or they can go to Chandler Hospital right upstairs to go get that. So they're walking out with that Narcan in hand, headed mostly by the Opioid Stewardship Committee, as well as the UK pharmacists. The thing that we've been doing for the last couple of years at UK for pediatrics, however, is a little different. So first we had to engage a lot of different pediatric providers, from ED, ortho, surgery, hem-onc, general pediatrics, adolescent, the ER, hospital medicine, to say, you know, is this something that you would be interested in providing to patients if we made it available and we had pediatric specific information? And they said yes. You know, anything that we can do to prevent these deaths, or, you know, to prevent significant morbidity related to overdose. So then the next step was that we created pediatric specific informatics for UK to use when they are disseminating the medication in a clinical context. So that had to be created as a group with ourselves, as well as the Opioid Stewardship Committee, as well as the UK pharmacists and other providers who were interested in the creation of that, which weren't that many. And we got that approved. And now what we're in process now, about a month ago, we met with electronic medical record folks, and this is kind of cool. But essentially, when there are certain electronic medical record triggers, like if a diagnosis gets entered, like an admitting diagnosis of different ICD codes that are most commonly used when a child ingests a product, which we basically had to go back in our database and say, what are providers using to code this, knowing that they code it all different ways, and find the most frequent ones. And then we gave that to the electronic medical, the Epic people. And then the other thing is that, you know, if they're being discharged and they have that diagnosis, essentially what'll happen is a best practice advisory pops up. So if you've ever used Epic, it essentially, like, as you're getting ready to discharge the patient, there's like a bunch of different screens. And essentially if they hit one of these three things, so the ICD-10 code being entered, a discharge order that includes an opioid prescription, say, you know, pain or whatnot, or urine drug screen positive in a kiddo less than 18 years of age, what ends up happening is the best practice, or what we hope is the best practice advisory will trigger as they're being discharged, and will say, you know, your patient had this. Would you like to, you know, it's best practice to prescribe naloxone for home use for this patient. If so, you know, you just have to click the prescribe button. It gets sent to the pharmacy. Pharmacy education kind of comes in, meds to beds, helps with that delivery process, because we think actually putting the medication in their hands while they're in the hospital is the best thing at this point. Because relying on people to go get it from a pharmacy, especially if it's prescribed for a child, might make them feel embarrassed or whatnot. So putting it in their hands while they're still in the room and giving them that education and then sending them home. So we're hoping that it apparently takes a really long time for electronic medical record things to get changed, but we have some really great people working on that, and we hope to get that kind of out and about. And this applies to more than just like our toddler population who we've mainly talked about. We want to, you know, engage all children. So it could be the 17-year-old who's showing up with a suicide-related overdose. It could be the 15-year-old showing up after experimenting with THC and not knowing that fentanyl is laced in it. So, you know, it covers the breadth of childhood experiences that could predispose them to, unfortunately, becoming victim of an opioid overdose. These are just some of the different informatics. So the one on the right essentially is the one I had showed before that had been co-developed, and we just recently in the last year developed the second page. Again, it's bright, it's colorful, it tries to give you kind of pockets of information that kind of help with the dosing. It tells you exactly how to use the naloxone. It tells you that you have to call 911 because it's likely that it's not going to be enough to just give them one dose and that they very well could still die. So, you know, it tries to be as upfront as humanly possible about what the risks are. And that's all. I'm not the most like stealth at like endings.
We're happy to take any questions from anybody or share resources if you want to adopt some of what we're doing in either a healthcare setting or non-healthcare setting. I think it could be used in a lot of different ways.
I will put a plug in for recovery community centers. They can provide naloxone. You don't have to pay $45, and
Yeah.
it's very quick, 15 minutes worth of brief overdose education. Give them naloxone and they walk out.
That's awesome. Yeah.
I'll put in a shameless plug. So they mentioned the firearm safety tip sheet. I'm Chris, Prevent Child Abuse Kentucky Programs and Trainings Coordinator. We love to give those tip sheets out. And so if you or someone you know might be interested in distributing those, you can actually order those for free on our website, pcaky.org. Free to order any of our resources, our print resources on there. You do have to pay shipping if you want to have it shipped to you. But if you're willing to come by our office and pick it up, other than the gas money that you would spend to get to our office, it is completely free. Also, on our website, after lots of work on Dr. Gregory's part, we now have an online training called Up and Away that is all about ingestions and safe substance storage, where folks can go in there and take that training. So it's a video, and then there are questions that you answer afterwards. And then you get a certificate from me in your email if you answer all the questions correctly or get at least an 80%. Really great for parents and caregivers or anyone in the community in general. Just really great information for folks to have because as we've learned, it's so important.
I think that has a little bit more practical information, like how to make it work for you in your home. So if that's something you're looking for. Shameless plug.
I do have a question. Do you know of a good source for distributing to the community's gun locks?
So you can utilize local law enforcement. Usually will have gun locks available, or KSP. Technically, when you purchase the gun from a gun store, they're supposed to provide a gun lock for you, but we know that that doesn't always happen.
Public health departments, we've been actually like delivering them to public health departments who've asked.
And I get
Yeah.
questions all the time about where can I obtain, and usually it's like a public health department or another nonprofit. Where
Yeah.
can I get gun locks to distribute at a health fair?
Yeah.
Say,
Whitney Strong, the Whitney Strong Foundation, if you want to order some to give out to whoever you serve, they have some. Project Child Safe has the ability to order some gun lock options to provide to families. And if they're in your community, we were hoping they would come to Lexington. They haven't yet, but if they're in your community, they provide them. And the VA is a great one too.
Okay.
and
Thank
general
you.
pediatrics clinics at UK,
Yeah.
as well as Norton. I used to work at Norton and they do that too.
Any other, okay.
I think I can be loud enough to.
Well,
Yeah.
it needed
Just
to
to get out
for
of
the
here.
recording.
No, but this is actually not a question, it's just a response to that question. Several firearm manufacturers also make gun locks available free. And if you have a gun store or sporting goods store with a firearm section in your community, if you talk with them, there's a pretty good chance they may be able to get one of the manufacturers whose products they carry to provide gun locks for you. I know from personal experience, there are several gun stores that you can find a basket of gun locks sitting on the counter free, take one.
Yeah.
So they're readily available, but you do sometimes have to look to the industry rather than to traditional safety partners.
Thank you, Robert.
So I just had a question, if you guys had any successes getting people to ask about the trigger locks and things using your signage up here.
Anecdotally, I've had in our clinic, I've had one person ask me about a trigger lock because of the signage. I haven't heard from our pediatricians, our general pediatricians, if that has pun intended, triggered a conversation. But that's something we should ask and haven't yet. This was just something that kind of spur of the moment they said they wanted. We're like, okay, here it is. So we should follow up. That's a good
Okay,
point.
yeah, because I had actually tried to create something like this, and so I was thinking maybe of doing something similar. I just haven't actually done it yet. So that's what I was kind of wondering, because I try to give out gun locks, because I'm in Lincoln County, so it's rural Kentucky. Everybody's got guns around there. Everybody's all about their guns. So I do give them out at like any event that I can possibly set up at, along with education. So yeah, I was just wondering about this and if that got people kind of asking that question.
No, but I do think it makes them more receptive to have a conversation because they know it's important to you. It kind of reminds me of like when the PSA came out for like HPV vaccines and stuff, you just saw it everywhere. And I feel like it made it more like of a socially acceptable thing. Maybe not, I don't know. That was my perception. And so the pediatrician who asked us for it had also kind of cited that. They're like, even if they don't ask us for what, it might make it, you know, it might trigger their memory to ask the patient, or it might kind of just serve as some like subliminal messaging that it's like an okay thing to talk about. I don't.
All right.
Any other questions?
Thank you all.
Thank you. Future would probably- It's trying to drag you through, but
Thanks for having us.
thank you.